Hello and welcome to today's webinar, CMS's New Interoperability and Patient Access Initiative and Impact on Payers. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen. We're very fortunate to have with us today Swanan Prabhutan-Dolkar and Guninder Bhatia. Swanan leads the Citius Tech Healthcare Interoperability, BIDW, Big Data Practices. With more than 18 years of experience in information technology, Swanan has worked across regulatory reporting requirements, such as MU, and healthcare standards and frameworks, including HL7. Swanan has also served as a senior architect for the development of Citius Tech's bi-clinical product. Guninder is a healthcare consultant at Citius Tech, with 10 years of domain experience in the healthcare IT industry, having worked with payer and provider clients. Certified product owner, having developed innovative solutions, she has worked on projects including business and market analysis, healthcare industry trend analysis, and consulting. At this time, I'd like to turn the floor over to our speakers as they share insights on how the new rule will impact payer and providers in the United States.
Hey, thanks, Catherine. And hello, everybody. This is Swanan here. Let's move on with the slides. And this is the introduction slide. Catherine did a nice job of it. So let's move to the next one. Okay. So today's webinar, we are going to talk about the new proposed interoperable that was proposed, of course, by CMS in the February 2019, and I believe we all know it. We'll have a look at the different aspects of the rule, what it entails, what it tries to mandate, or maybe tries to bring in the changes to. We'll also look at some of the timelines of earlier rules that CMS had brought in just a quick summary of what has gone in past few years, and I'm sure we all probably mostly know it. We'll also try to look at the impact on payers in terms of the new ways of data exchange, the new regulations, when the member switches a health plan. What kind of access they have to provide to members, what kind of power they have to provide to member when member can control his or her clinical data, etc. And while doing all of this, what could be the technology changes payer might have to think about, payer might have to look into, or might have to go about. Also, in the webinar, we really would like that our audience to share their thoughts and questions, as this webinar is aimed at enriching all of us, while the rule is yet to be finalized. So since it's not yet finalized, we are also digging into it. We are looking at it. We are trying to get more and more information out of it, and that's the reason why we thought it's more of enriching for all of us. So from my side, if you ask me, well, I'm as much interested in receiving thoughts from you all as much I am interested in sharing what we have so far collectively dug into. Now, without further ado, let's get going. So here is the agenda, and the first, we'll look at the webinar rule itself. What is the CMS IPAP rule? What are the different aspects of it? Payer ecosystem, how it is today, and what it could be in future. What we feel it could be in future once the rule is operationalized, and if it is operationalized. The use cases that will be impacted and impact on payers. And then what's next? That section will try to find out how to best approach to bring in the change. We have certain thoughts around it. We'll try and talk about those. There are certain dilemmas that people may have, and we are trying to bring those around as well. So before we begin with the actual webinars, we do have a polling question as well. And by the way, we do not have many. We have probably 2 or 3 polling questions. So I guarantee that you don't have to answer too many times. But to begin with our webinar, let's have a look at the first polling question. Catherine, can you bring in the polling question, please?
Audience, it should be on your screen now on the right side.
Yeah, let's give people maybe like 15, 20 seconds or so. So it's about how do you rate your awareness of the CMS interoperability rule that we're going to talk about. And yes, it could be that you know it. You probably know the rule, but know the details, and probably you're unaware of it. Okay, Catherine, looks like you stopped the poll, is it?
Yes.
Okay, so yeah, you can publish it, and looks like 65% of our audience today know that there is a rule, but probably they don't know the details. A good amount of people, they are aware of the rules as well, and they are following. So that makes my life a little bit not so easy. We probably need to do a very good job of bringing people up to the speed, and we'll try and definitely do a good job of it. So let's look at EMS interoperability. What has been happening in past few years, maybe last 10, 15 years. Here is a quick memory refresh for all of us to look at some of the notable changes that we had seen in past 10 years. It goes back from 2004. We saw ONC getting formally created, the rise of Health Information Network, which we used to refer to as in those days. Sometime in 2008, 2009 timeframe, we had High-Tech Act coming in, and we saw about 20% kind of adoption by EHRs. So that was from 2004 to 2009. The next 3 years, so that is 2010 to 2012, we saw stuff like Blue Button Initiative, and that time it was HL7 version that came up. Meaningful Use 1 coming up, and the launch of CCDA as a derived standard for communicating clinical data. Meaningful Use in some ways mandated CCDA for data exchange as well at that time. These were some of the initiatives which were there in the year of 2012 to 2010 to 2012. So the next one was FHIR that came in the picture little after around 2013, 2014 timeframe, and after that Argonaut project was also launched. That was of course using FHIR. I keep saying FHIR, but yes, it's same as FHIR. And we all know that Commonwealth Alliance also was being formed sometime in 2015, 2017 timeframe, and Meaningful Use Stage 2 was also around. And attestation started, people had to comply with it, they had to send in data. That's all that started around that time. In 2018, we saw this last year Blue Button Initiative being relaunched as Blue Button V2, and this time it was using FHIR as the communication standard. My Healthy Data was also launched, and Da Vinci project to bridge the payer-provider data exchange. And this was all again using FHIR. So we saw that FHIR has been on the rise, and there have been conscious efforts made by regulatory bodies to bring in those changes. If we say that the way it has moved, the efforts have been towards bridging the payer-provider data gap, and of course providing more power to members and patients to control their data in terms of who can access, who can share, and whatnot. They're trying to empower the end users whose data is. They're trying to empower those guys a little bit more. The last and most recent initiatives is the IPAP rule that was published in 2015, which again deals with data exchange, interoperability, and patient access. This is the latest of that, and that's what we're going to talk about today. With that history, so let's move on to the actual rule. And yes, before that, we have one last question from our side to ask all of you, and that is, Catherine, can you just bring in the next question, please, so that sets the ground for our remaining webinar.
Yes, it is running.
Okay.
This question is, which is the most dominant barrier to the way of interoperability?
Yeah.
Structured data in healthcare enterprises, lack of HHS or CMS support, integrating new solutions with legacy systems.
Yeah, let's wait for 10 more seconds or so.
Okay, I'm going to go ahead and
Okay.
finish.
Okay, that tells us 54% of the people are stating that unstructured data in the healthcare enterprises is the most common barrier. And the second one, that is like 41%, are stating that new solutions with legacy systems. And I guess that's integrating new solutions with legacy system is something that probably we will touch upon today in some ways. Unstructured data is something that we are not going to touch upon today because the rule that we are talking about going to deal with fire, and how do we enable us and how do we embrace for the future is what we are going to look like. With this, let me hand it over to Guninder, who will take us through the rule, the different aspects of the rule, and what are the use cases. So Guninder, over to you, and looking forward to better.
Hello everyone.
On the slide.
And thanks Swanand. Well, Swanand has nicely briefed out the journey map on interoperability progress and also helped us to pull out the most important barrier while going through on this interoperability journey. That is the unstructured data in healthcare enterprises. Well, if we go ahead with the ONC survey report, they have also mentioned that unstructured data is one of the main contributor to the long-standing inability of healthcare providers and insurance companies to find a way to exchange patient data. Well, early this year, CMS has also come up with a proposed rule for the interoperability and patient access, with the aim to strive for greater interoperability and truly empowers patients or members to obtain and share their own health data with the ease and with the secure connectivity. So let's see what the rule brings up for us.
Here on the slide.
So this proposed rule applies to state Medicaid and CHIP agencies, insurers that are qualified health plans, Medicare Advantage plans, Medicaid and CHIP managed care plans, and also for the Medicare and Medicaid healthcare providers. While currently the broader commercial market, the employer-sponsored health insurance and standalone dental plans are exempted from this rule. So this rule spins around 8 key aspects. The blue ones are for payers and the gray ones are for the providers. So the first one says the payer needs to exchange patient health data. The second one is to improve the cross-payer coordination. Third one says the payer needs to publish provider directory data. The fourth one goes with the participation in trusted exchange network. And the fifth one for payers asks to improve the dual eligible individual experiences. While in the same way, let's go with the provider. The first one asks for the provider digital contact information to be published in the online channel. The second asks the prevention of information blocking. And the last one is to send and to share ADT patient event notifications. So let's take a deep dive going ahead with our few slides. What is it all about for the payers? Okay. So the first key aspect for the payers say that the patient health data exchange. It requires payers to available the member information like the claims information, the encounter data, enrollee cost sharing, or any other health information related to the patient like the lab result to be available electronically through different APIs. CMS has also proposed the data exchange requirements that define both the types and also the technical approach and standard to be followed while sharing the information. The one key requirement to implement and maintain these open API is using FHIR, that is the Fast Healthcare Interoperability Resources, which is a standard given by HL7 for exchanging the healthcare data, and which allows third-party application to easily retrieve variety of information. CMS not only this, also specifies the response time for sharing information via APIs. That should be no later than 1 business day after the claim is processed. So in nutshell, we can say this is a push to envisage the healthcare ecosystem with a standardized data content and also a web-based technology through which payers can share patient health information data with the third-party apps and other innovators or the developers, thereby simplifying and enhancing interoperability. The next one is the cross-payer care coordination. So what the rule asks now, the rule is giving a provision for the members when they switch their plans, they can also access their previous health information that is residing with their prior health plan. So if I say today I am holding a plan with Humana, and after a year if I am switching to United Health, so on my request, Humana should be able to share my previous health information to my new health plan, that is United, or to any third-party app which I am designated to receive data from. Although, here the bulk of data has to be shared by one payer to another, which in any which case help in improving the care coordination. But as we feel this is a real good provision to provide members with a longitudinal health record that the member can access through the third-party applications and can easily keep an eye on their health spending, doing comparative analysis on their health vitals, or taking any proactive measures to control their health risk. These are few set of examples that I just said, but later on also I have a full detailed discussion on few more use cases in this session.
So Guninder, is it that we feel the payers would probably query to the earlier payers? Have they really specified anything of that sort? Or is it that, I am Humana in your example, so I'll push it out, I came to know that Guninder has changed? Or is it the new payer will query and the earlier payer will have to share in some way?
So the provision go ahead with the member's consent and with member's request. If the member is asking to switch his data from his previous or prior health plan, so they can switch it, and the member can have access to the new health plan.
In some ways, if I don't say don't send my 5 years data to the new payer, then in your case, Humana will probably not send. Something of that sort?
Yeah, Humana will not send, but Humana should have the capability to store at least 5 years of his data.
Is fine. Yeah. I'm just saying if I say that don't send it out for last 5 years, then they will not be, because I am restricting it.
Right. It depends on the request only.
Okay. And consent by the member.
By the member. Okay. True. Right.
Fine. That's it. Thanks. Go ahead.
Okay. So going ahead with the third provision, that is the publish of provider directory data. So now the CMS asks payers to maintain and publish provider directory data with the latest update no later than 30 business days, and that too through the open APIs. This will improve the accuracy of health plan provider directory, but also facilitate members to access anywhere, anyhow, using APIs and using third-party mobile apps, the providers in their network and outside their network with an ease. Okay, well, the fourth one is around the participation in trusted exchange networks. So the payers under CMS programs now need to participate in trusted exchange networks with the capability of exchanging member health information between peer-to-peer or between peer-to-provider outside the set geography or the networks to which they belong. So now I'll just touch upon what are these trusted exchange networks. Basically, these are nothing but the network of networks which base on certain set of principles and also some ground rules for sharing data between the HINs and the HIX. Although the trusted exchange networks are not yet fully defined, but what we feel, this will allow a broader interoperability beyond one health system or a point-to-point connections among payers, patients, and providers. So such networks will establish rules for the journey of interoperability, and with mature technology, they will gain momentum with participants, including several federal agencies, EHR vendors, retail pharmacy chains, or large provider associations and others. On top of it, these trusted exchange networks will be binded by a framework called TEFCA, which will provide them certain guidelines to how to participate in it, certain policies, requirements, some technical specification, and also some governance processes to operationalize the data sharing under approved principles of trust. Okay, so going ahead with the fifth tenet of the rule that says how the rule can help to improve the dual eligible individual's experience. So what CMS is asking for? CMS is asking for to increase the frequency of federal state data exchanges for dually eligible individuals from weekly or monthly to the daily basis. So what happens in monthly exchange? It takes months, multiple months to correct and resubmit an improperly processed transaction, which not only adds on the delay in assigning the premium liability, but it will also lead to larger mispayment and redistribution of premiums by the federal government. Thus, to avoid all this and to improve coordination of benefits and also to reduce misallocation of funds when the enrollee status is getting changed, CMS is thus encouraging and proposing to exchange this buy-in data on daily basis. Okay, so these are few highlights of the rule on the payer side. Let's see what the rule brings for providers. Okay, here we are. So with the proposed rule, CMS is proposing some series of interoperability changes to its condition of participation. So when it is condition of participation, that applies to the Medicaid and Medicare participating hospitals, which now would be required to send automated patient admission, discharge, or transfer notifications immediately or at the time of the event to the other facilities and to providers which belongs to the patient. I would say CMS has just limited this implication only to providers, but if we go with our point of view, if these kind of timely information is extended in scope and shared with the care managers, it would be a real key contributor for payers to close gaps in care coordination, and it will also help them in improving care management programs. Well, going ahead with the next one on the payer side, that is the prevention of information blocking. So what it says, the CMS is now proposing to publicly report the names of providers that attest to any activities that could be considered as information blocking. So any practice that limits interoperability purposely or otherwise could be the part of information blocking. It could be any practice of restricting authorized access or exchange of information due to any non-standard technology implementation or due to inability of EHRs to exchange data, which I feel is a really good initiative which the CMS has come up to disclose the bad actors in Hall of Shame. And anyone who is complaining about any other providers who are the part of information blocking, their name will be protected from disclosure as per the Pure Act also. Okay, and the last one is around the provider digital contact information, which again asks all the providers to maintain their contact information on the national plan and provider enumeration system. That is the online system where their digital information should be there. And again, failing to do so, they will again the part of Hall of Shame. Their name would be listed on the CMS portal.
Okay, that's good. Gurinder, just what could be a blocking of information would be? So I ask for something and you don't comply. Is that what is blocking? Or can I hide behind, say, my IT systems? And well, my IT system is an old one, and it just doesn't have the way to do it. Can I hide behind it, or I no more can hide behind it?
Okay. So earlier, if that would be the scenario, the providers can hide behind considering the incapability of their health system. But now, with the proposal of this rule, even though their systems are incapable, they will be listed out.
They'll be listed out.
So better they should go ahead and improvise their systems, their EHRs, where these kind of restrictions would not be part of.
Okay. That's fine.
So this is what we have as the few tenets or the few key aspects of the rule. Let's see what the rule timeline is. Okay, as we all know and we are aware that recently in this year, 2019 Feb, this proposed rule got published, and it was targeted to have the comments by 3rd of May. But unfortunately, or fortunately for few of us, it got extended till 3rd of June. And now, as per the implementation timeline, the rule says the API implementation for the MA payers should be by Jan 2020. And for Medicaid and CHIP managed care plans, it should be by 1st of July 2020. And also, the payers need to get registration or participation in trusted exchange networks by Jan 2020. As many of our industry experts have commented, and the same do we hold an opinion, that the timelines are quite stringent. If the rule gets finalized, the payers really need to gear up to get aligned with it. But we would suggest rather the timeline should be little relaxed so that the payer can go slow but accomplish more to get compliant with the rule. Well, so this is what we had as a summary of the rule with the key highlights on the payer and the provider side. So now let's take a look how the current payer ecosystem for the data exchange look like and what is our point of view for the futuristic payer ecosystem. Okay, here we are. Let's see the current state of art of payer data exchange with payer and the other entities. This schematic flow shows the current state of payer ecosystem while highlighting few key challenges. Here we all can get aligned that the payer exchanges varied type of data like financial data, clinical data, operational data with external entities like members, providers, HIEs, trading partners, and others. All these different type of data are exchanged in multiple varied data standards. Either it is X12 or it is HL7 or CCDA or any other custom format like XML, .csv, and so on and so forth. So, to ingest and process these varied data formats, payer use multiple parsers or other technology platforms, which not only adds to administrative overheads, but also creates a messy ecosystem for payers to exchange data. Also, day in and out, payer systems exchanges data and store huge set of data, which contributes to have a huge hub of data at their end. But due to disparate and disconnected data systems, because of unstructured data formats, This could not help neither in member transparency nor in care coordination. Thus, through this CMS rule or the initiative, which recommends the one standard format for data exchange, that is FHIR. So thus this rule, when comes and brings the FHIR-enabled APIs, will help the payers to come out of this messy situation and help in building a connected and interoperable healthcare ecosystem to fully realize the benefits of digital health. So
the picture that we see is more of the way we think the payers are currently doing. What I believe is, there will be some exception. They will be doing differently. But on a broad scale, what we have done is we have tried to cover an ecosystem. Whichever payer we have worked with, we have figured out, okay, these are the kind of interfaces they would be having. Again, this is more of an indicative one, and not really a schematic, which is more of a descriptive or a instructive schematic.
So let's go ahead and see what we envisage as a futuristic state for payers.
Go ahead, Brenda.
Okay, so as we have seen, there are many spurring challenges in the payer current ecosystem with respect to exchanging data with the external entities. Now we go ahead with if we go ahead with the moving wave of interoperability and to get aligned with the CMS rule, we envisage a futuristic state where FHIR is going to be a catalyst for driving interoperability. The same data sets, like for the financial data, the operational data, the clinical data, now will be exchanged using FHIR resources rather than any other formats, which we have currently. But instead of multiple parsers, which the payers are currently going ahead, and the other technology platform, now we'll be replacing that with the single FHIR gateway. This FHIR gateway will be attributed by FHIR interface services to transform, to standardize multiple varied data formats into one standard form. FHIR interface services would also help in setting up FHIR endpoint connectors through which the bundled FHIR resources, like instead of PDIs for claim, now we may have claim response resource, bundled together to exchange via APIs as per the requirement. Thus, we view the FHIR-enabled APIs and this new ecosystem, which is braced with FHIR interface services, would eliminate the need of multiple parsers. This will reduce the administrative cost and will also brace the digitally connected healthcare ecosystem with increased involvement of members in their own care. Thus, the futuristic state using one single form or one standard form of data exchange will help in improving coordination of care across different payers, across multiple providers, and will help members to have control of their own health using their own health data, thus promoting the continuity of care. So this is what we envisage as the futuristic state for the payers when they go ahead with the running wave of interoperability, and also it will add on to the how to get aligned with the rules.
Okay.
So going ahead, I'll be touching upon few use cases which I have collated and listed down here in my next slide. Although we have already touched upon little bit in my previous discussion, but still, just to aggregate the full set of use cases, that would be helpful for a lot of us to understand.
And we'll be making this presentation anyway available, so we just thought of having a list and on one slide where if you access this offline, you will have all the use cases that we thought as a ready directional for you. Go ahead.
Okay, so let's see how and what all different kind of use cases we have with the impact of this rule. The first use case is around the member data. So as per the first ask of the rule, which requires sharing and enabling easy access of member data. And with the use of FHIR-enabled APIs, the member data would be easily available to enrollees via third-party apps. So where it would be really handy for members to check out their latest claim status in near real-time view. They can check out their enrollee identifier, date of service, payment information, provider remittance available. Also, the kind of the clinical data that would be available to them, for example, the lab results or other reports. It will be very handy for them when a member is going for any follow-ups for the providers. Also, it will make the cost distribution in their hands when they are in any state of confusion. So they will be well aware of their share and the other kind of the payment distribution like the co-pay and co-insurance. Okay, so going ahead with the next use case, that would be around the member historic data. Okay, so the member historic data, if it is available with the members, that can help them in their clinical decision support making and also help them take proactive health measures to improve their own health by doing comparative analysis of their vitals and other information. Well, if I talk about the third use case, that is the provider directory information would be available to members. Now the members can search for their practitioner either by the demographics or by any city code, any region, or by the name, or with practitioner in any specific specialty. Well, just to add on, as per the report by ONC on Health IT Quick Stats in 2018, they say like 42% of members uses smartphones for accessing provider directory information. And also around 40% of members use smartphones for tracking their charges and cost. So well, I guess these kind of use cases where the FHIR-enabled APIs are there would really serve the purpose. And now the last few, that is the participation in trusted exchange. As we already know now, the participation in trusted exchange network will broaden the scope of interoperability. So it will become easy for federal or the state agencies to come in the network and determine the qualification of benefit for individuals who are either federal or state beneficiaries. In the same way, the health plans can also provide reimbursement for the provision of care while interacting in between the networks. And lastly, the clinical alerts to the PCP and the care managers. This is one of the prospective use case. That is sending clinical alerts for any specific event like for the admission, discharge, or any change in treatment. But as I mentioned earlier, CMS has confined the implication only to the providers. But in case the scope is broadened and the payers can also get a chance to get these kind of notifications, this will really help them to build an encounter record for the members and also help them in scheduling timely follow-ups as needed. Thus, in real sense, I would say it will improve the care coordination and management and as well as act as a trigger for quality programs and other member-focused activities like for risk adjustment and identifying high-risk population. Okay, well, this is all I have on the functional side of the rule. I have briefly summarized what the rule is, what the current payer ecosystem, and also our point of view on the futuristic state of the payer ecosystem with some prospective use cases. Well, let's have Swanand to take us through the impact on the payers and also what now payers need to do while they get aligned with this prospective interoperability initiative. Swanand, over to you.
Yeah, thanks, Gurinder. let's look at the impact on payers from technology perspective. I come from the technology background, so I'll probably touch upon that. And also what's next. So if you know how do you achieve it, of course, we will try and figure out one or two ways out of it. Before that, just the last thing where I'm going to ask you people to answer for me. And Catherine, can you please bring up the question? The question is, what is the most important and immediate change to go for CMS interoperability rule? And well, there are 4 answers this time you have to choose between. Yeah, let's give 10 more seconds. Okay, looks like we have probably kind of a consensus. That is the first one, that is data aggregation into a central uniform data platform, is something that people have voted for, 47%, and the second highest is enabling FHR web services. I kind of guess this is how the answer is probably going to be, but we just thought that we'll have a poll around that, just to ensure that yes, people are probably following us. Anyway, let's go ahead and talk about the same thing. First things first, there is a change, and what does that mean? That means change in IT infrastructure, and of course that is for API enablement. CMS is talking about data exchange using API, using FHIR standard. So there will be a new IT infrastructure that will be required in terms of software, hardware, whatever, and people will have to adopt to the new way of exchanging the data. They probably have to build upon their existing health IT infrastructure, but they'll still have to change. Second one is enable bidirectional data exchange. This actually is again required, and the IT infrastructure that we are talking about will probably enable this as well. Bidirectional in the sense that payers will have to exchange data with other payers. They'll have to exchange data with the provider, getting in from them, and the next one is enable IT and technical standards for data aggregation. This actually goes back to one of the the popular answer for the poll, because now we are going to receive a clinical alerts ADTs from the providers. Also, there is a requirement for 5-year-old data, rather 5-year historical data to be sent across. So aggregation into central unified data platform, something that will be required. If it is not already done, I believe that payers are mostly doing it, but if they still have some sort of a siloed system in between, they'll probably have to, now is the time that to get into a central unified data platform. The next one that I'm going to the next slide here, and the next one is, of course, go for a simple reusable solution. This is more of a preaching from our side. But yes, it's always good to have start simple, start slow, and then move on, and that's what we are thinking about. Start with wherever possible, deploy a simple solution. Guninder, you are moving ahead probably with the slides. Okay, sorry for that. So wherever possible, go for simpler solution, and allow for more complex method probably in future. Participant trusted network. Out here, the trouble is this is something that we will have to do. Mostly, we believe that trusted exchange network will probably be adherent to FHIR standard, but it is not defined. So it is possible that some of the trusted exchange network would still be on probably HL7, and then for that one, we will have to go in for that by the time, until the time they are not moved to FHIR standards. And the last one is enable easy access to the members. So health data for the members, they should have the access to it. So there will be some amount of patient portal, or maybe a mobile app or something of that sort needs to be created. And this goes back to the second answer of the polling question. Yes, we need some sort of patient portal, because that's the one we are going to use to enable members to access their health data. Also, that will be a point where we can tell our members that using this you can tell us who should be accessing the data. So if I as a member, I need to tell my payer that allow this data to be accessed by my other payer, this could be the place where we can get all sorts of member consents and all. So these are the things that we felt that payer needs to do in order to get ready for this change. And moving on, what experts say. This is the slide we thought that we'll collect what everybody is talking about this in the world. Yes, MEI is saying that CMS is too aggressive. AHIP itself is saying it calls for phased approach. HIMSS guys are saying API requirement is good, but slow down on the trusted exchange requirements. ANG is saying interoperability platform should boost the claim. And if you look at it, no one is saying it's something which is not good. Formal coordinator are saying yes, call for a delay, and rule is taking more phase in approach. So all of them are saying that this is something which is required. This is something is a welcome change. But all of them are probably thinking that it's little too aggressive, or it's a little too much too soon is what I am thinking. And that's exactly what probably you guys are also thinking, but this is what we thought we'll collect from industry and put it up. Now the next slide. Well, how do you start with the interoperability journey? There are two things. One, you would have a long-term strategy, and the other one is short-term goals. The long-term strategy obviously will end up in have more cost upfront, but it will be an end-to-end comprehensive solution. And in that case, it will be a consistent approach for whatever you are doing. Always strategize long-term, but it would probably take a longer time for you to build it as well. So how do you do it? Quick fixes. So that's where the short-term goals come in. What you achieve out of short-term is the quick fix, but then that would still leave your internal ecosystem fragmented. And well, there could be recurring costs arising out of it, as and when you keep getting new systems coming in, new opportunity or new changes bringing in, you'll have to keep making a lot more changes internally. And I'll come in a minute to what do I exactly mean by this. But I believe this is the kind of a dilemma people would be having. Should I now go in for a long-term strategy, or should I focus on short-term goals, or so on and so forth? I think I am skipping the slide, and the strategy solution is this way. Short-term gains, they will delay your long-term goals in some ways, correct? But how do you do it? So what we think is following. You probably would be having interfaces for external parties to give you data and to share with them. The first thing that we felt is change the interfaces to FHIR, change the interfaces to API, but keep your internal systems the way they are. And what does that mean is, let's say there is an internal system which is taking currently X12, maybe HL7, or maybe CDA as an input, and now what we are going to tell world is, now give me FHIR, and they would give you FHIR data, and the internal systems are still accessing HL7. What it would mean is, we'll have to convert from FHIR to HL7, or FHIR to CDA, or FHIR to whatnot, and keep the internal structure as is. We may have multiple internal data processors. Do not change them. Just keep them the way they are and feed them what they need. And when you get the data back, convert it back to FHIR and send it to the external world. And that's what we mean by what is the fastest way of doing it. If you already have a nice interface engine, or maybe head effects of the world or MERS of the world, and if they start supporting FHIR, then that's a way you would go for. You would probably upgrade to the new version of FHIR and then upgrade to it. But that is again going to solve your interface problem, but it's not going to solve your the processing and your storage problem. But that you can keep for the long term. And this is where we talk about how my short term gains lead to quick wins for the long term. So my long term strategy. My interfaces work is already done by my short-term application. So I do only interfacing in short-term, and then I sit back and decide, okay, what my long-term strategy should be. Do I need to go in for a change of my data model because now I'm accessing more and more FHIR data coming in? Do I need to go in for some sort of a different technology altogether? All that is something which we feel that are the long-term goals. While you are doing your short-term goals, you are going for a quick wins. What I and we at Serious Tech strongly feel is that you should not get your eyes off your long-term goals, and you should probably be doing course correction whenever required. But yes, there will be a long-term strategy, and that you will anyway be starting doing. Of course, should and all these things are the they will come into effect should this rule comes into operationalized. Currently, it is still proposed, and we believe it will be operationalized at some point in time. But it will be as a long-term strategy, as a strategy for the future. It will be great to have an integrated and consistent solution enabling FHIR capabilities, FHIR interfaces, and processing at the back. And that's where actually we thought of ending the webinar. We got 9 more minutes, and we have got a lot of questions coming up. So I'm going to take up some of the questions. So let me just go through the questions here, and there are many of them. And I'll take up one of them, which seems pretty fast. So one question, it says, how is the other plan in the use case 2 is defined? Which is going to talked about the other plan in the second use case is basically the plan to which the member has migrated or member already has relationship with. So I as a Swanand, I'm with Humana, she gave that example, and let's say I move to whatever, Anthem, Aetna, and then the other plan could be that one where I as Swanand has moved to, or I as Swanand has a relationship with. So that's what Guninder meant by other plan and on the use case 2 in that slide. I think it was slide 19 or so. Yeah. Let me take another question. Gurinder, you have one more?
Yeah, okay. So I'll take another question, which says, how much is the overlapping does this initiative have with the Blue Button 2.0? So, well, Blue Button 2.0 also came up with the same API-based program for the beneficiaries to access their health data, specifically for the claim data that to be available electronically through the APIs and through the certain set of applications the CMS owns. But this rule comes with a much broader scope. That is, it is giving member health information. Also, along with that, it is broadening the scope with setting up a one standard data format. Also, giving a scope to have a participation in trusted exchange networks and in improving dual eligible patient experience, dual eligible individual experience, So, when I say overlapping, the only overlapping here is they are using the same technology landscape, that is the open APIs, and the difference is here now the much broader scope is along with the claim data, now the member can see the clinical data, the encounter data, and the other enrollment data also. And all these data is outlined by the US CDI format, which was earlier not there with the Blue Button 2.0.
Yeah. I'll take up the next one. I mean, there are many questions, folks, believe us. I think that there's a list of around 15 all in front of me. We'll try and take up maybe 3 or 4 more as we have 6 more minutes left. But what we will definitely do is, along with this, along with the PPT, when we make it available, we'll make available the answers as well. So one question is, do you anticipate the HINs and TNs will eventually displace the need and demand for health plans to exchange data to third-party apps through their own APIs? It's a difficult to answer kind of a questions, because what you are hinting at is right. If the HINs and TNs have all the data, and why they have all the data? Because payers are now mandated to exchange data with them, and if they are storing all the data, then the third-party apps can directly go to HINs and TNs and get whatever data that they want. That is something which in future probably, if you ask me, yes, they can do it, because if I am going to write an app, and I'm thinking about it from an app writer's perspective right now. So if I'm going to write a third-party app, then I would probably go to a place where I get more data at one place rather than going to multiple places and get the data for one patient. And I'll probably go to one place where I get the longitudinal data of the patient, rather than again going to multiple places and then to do the patient matching and then do it. So if yes, in future, if this really happens, I as a app developer will be tempted to go there. Will it really displace? That's a tough to answer. I really don't think it would really displace, because we really do not know how far this is going to move. But definitely, if this happens, then that's going to be a really great thing. There is one more question that we have seen here, and that is, if I already have HL7 EDI connectivity, how much of my existing technology investment can be reused? And again, this goes back to the short-term and the long-term kind of answer that we talked about. The short-term answer is yes. All your internal processes you can reuse, provided you give an FHIR interface to external world, access data in FHIR, get data in FHIR, convert it to your EDI or HL7 format, whatnot, and simply reuse all the data processing that you currently have, and don't invest in the changes in the data processing, at least in the short term. But in some ways, in the long term, probably we really feel that we'll have to go in for the changes. And that brings to the next question. That is, what is the scope of the effort that payers with no API infrastructure, so payers who do not have any infrastructure support currently, what is the scope of effort in terms of timeline, staff, and cost they should expect? Honestly speaking, I really don't have a clue about this payer system. So
I think it will depend on different payers ecosystem.
Yeah, it depends on the payer ecosystem, but that's a question, and I really would love to answer this kind of questions, not on this forum, but in probably an RFE forum, but not here. I really do not know, what is it. But yes, we are looking at, again, this to answer this question from a short-term, long-term perspective. In short term, we are not looking at making too much of a investment as far as interfacing is done. That much API needs to be created. Shouldn't be a big thing, is what we really feel. The long-term approach, what we were talking, that will take longer. That will take more effort or so. But just to have a layer of FHIR for external world to communicate with you, that shouldn't be something which is a huge effort. People now know how to interact, how to write API using FHIR. There have been efforts like Happy and all. They have FHIR server. In fact, Azure also has come up with a FHIR server and FHIR support. So even if people are looking at going for cloud-based development, of course they can do it using Azure's FHIR capability as well. So those just to have an interface out there, I personally feel shouldn't be taking long time. It could be a short term or a short to medium term kind of a goal. But yes, to go in for a bigger thing, it's going to be a long term, medium to long term kind of a goal is what I really believe. And Catherine, I think we are in the last 30 seconds of the webinar now, and I still have probably 8 more questions to go for, and I probably will not be able to do that much the justice to those many questions. So what I believe is I would stop here.
Okay, all right. Well, I want to thank you both for that great presentation and for sharing your thoughts with us today. I want to thank you to our audience for participating in today's conference. That does conclude this webinar. Thank you again, and enjoy the rest of your day.
Thanks, everybody.
Thanks, everyone.